Hi guys, this is Lakshay. Today I'm going to be talking to you about COVID-19 and its cardiovascular implications. This is something we haven't really talked about since the beginning of this pandemic or since the beginning of this video series, but I think now we are more than a year into this and we can started making some sense out of the data that we have, and it is critical to talk about this given how common the cardiac effects of COVID are. So I'm going to put this down into three main categories, which is acute coronary syndromes, arrhythmias, and heart failure/cardiomyopathy, and we'll go into each one of them briefly. The mechanisms, I'm going to just name them very briefly, and they are all sort of same, and they go into this three different eventual pathways. Before we get on to this, I think it's important to talk about cytokine storm, which has received a lot of media, a lot of press attention over the last year, and there have been multiple articles in the mainstream media talking about cytokine storm. So let's briefly talk about that to start with. So what is cytokine storm? What are cytokines? Cytokines are nothing but they are small cellular proteins which help in signaling or transmitting the cellular signals and telling your cells what to do, where to move. And examples of this could be interleukin-1. There are so many of them. Key mediators of inflammatory of the cytokine storm are IL-1, which is interleukin-1, IL-6. We have got an antidote or antagonist for this now rather than antidote. Antagonist for interleukin-6, which is tocilizumab. And the other one is TNF-alpha. So these are the key cytokine mediators or cytokines, and when their levels go over the roof in a profound inflammatory state in an attempt for your immune system to fight an infection that can be a virus or a bacteria or any other infection, there is often some degree of damage to your body as well, which is what sepsis is. So sepsis is nothing when there's a fight between the immune system and the microorganisms. You end up doing some damage to your own body, which is sepsis or septic shock, which is essentially called the cause of end organ dysfunction. What happens in cytokine storm is there is a dramatic increase in the levels of these inflammatory mediators. Other ones can be CRP or ferritin or white cell count. When they go over the roof, there is a significant damage to your body, which is called as cytokine storm. It can cause basically any symptoms from head to toe, and the treatment is just supportive, controlling or taming down your immune system with steroids, sometimes immunosuppressants, monoclonal antibodies. We've got one for interleukin-6 with mixed results. We're not going to talk about that today, but let's just talk about the cardiovascular effects of COVID. Now, I mentioned cytokine storm to start with because this is one of the key mechanisms by which there is damage to your heart. There's direct damage to your heart. In the beginning of the pandemic, we thought COVID is just a respiratory pathology and it causes type 1 respiratory failure, hypoxemia, which sometimes can cause myocardial dysfunction or myocarditis because of hypoxia, or even a rise in troponin because of hypoxia. Now we have realized COVID can actually cause direct myocardial injury, direct myocardial damage, direct myocardial apoptosis because of endothelial dysfunction. Let's talk about ACS first, which is the first key problem which COVID is very well known to cause now. So if you get a patient with fever, some flu-like symptoms, they come around, you do an ECG, a little bit tachycardic, you see obviously classical STEMI or myocardial infarction sort of ST elevation. Now, could that be myocarditis or is it a true STEMI? So there's actually no way to differentiate between myocarditis and STEMI based on the ECG or even based on the troponin. Both the conditions will cause some myocardial injury, and troponin is a marker of myocardial injury. So troponin is also expected to go up in both the conditions significantly. First troponin would be up and the second one might go higher in both the situations, in both the conditions. So with the ECG, you can't differentiate between myocarditis or STEMI. We've got a history which suggests COVID with fever, cough. COVID can cause myocarditis. COVID can also increase your risk of STEMI. So again, the history doesn't leave you anywhere. So you can't use history to differentiate. You can't use ECG to differentiate. You can't use component differentiate. I think this is quite a difficult situation, and given the current climate, we should probably err on the side of calling it a STEMI. It's best to have pre-existing protocols with cardiology in terms of what should be done for these patients. Ideally, they should be taken to cath lab or for an angiogram to look for an occluded coronary. If that's clean, then yes, we can treat myocarditis, which will be supportive COVID management, taming the immune system, intubation, oxygen, maybe some dexamethasone, and supportive care. If that's a STEMI or that's a myocardial injury because of an ischemic event, then they need a stent. So it's better to call it STEMI and then go to myocarditis route rather than the other way around when they will have a significant myocardial damage because of ongoing ischemia if we treat with supportive care, calling it myocarditis for first 2 or 3 days. Now, how COVID causes that? Now, again, the problem is profound inflammatory storm or cytokine storm, profound inflammatory stimulation, sympathetic stimulation, which can cause endothelial dysfunction and direct myocardial damage as well. Now, that was about ACS. I'm going to briefly mention about non-traditional, some non-classical ACS risk factors as well. Talking about inflammation now, we used to think cholesterol is the problem. Cholesterol blocks your blood vessels, and then that causes angina or peripheral vascular disease or ischemic sort of symptoms. But I think the problem is chronic inflammation, not just high cholesterol. Chronic inflammation can be caused by any long-standing inflammatory disease. Connective tissue diseases, they are really big factor for having clots. Pulmonary embolism in SLE, common. SLE is also a risk factor for giving you acute coronary syndromes. In fact, any profound long-standing inflammatory state like CKD, long-term cocaine use is also inflammatory, and it is atherogenic as well. That can cause ischemic events. HIV is a long-standing chronic inflammatory state which can increase the risk of acute coronary syndrome. So these are all the non-traditional risk factors: SLE, connective tissue diseases, other diseases like renal failure, chronic renal failure, and HIV. They can certainly increase your risk of acute coronary syndrome. So it's worth checking for these in somebody who comes with history of chest pain, which is concerning. Coming to number 2, which is, we've talked about ACS so far. Number 2 is arrhythmias. Again, sort of similar mechanisms, COVID-related myocarditis because of sympathetic stimulation, cytokine storm, myocarditis, and then they eventually go into arrhythmias. The key arrhythmias, the common ones to remember would be atrial fibrillation, sinus tachycardia, torsades, and ventricular arrhythmias as well. So COVID is very well known to cause all these arrhythmias because of similar mechanisms, profound long-standing inflammation. In fact, there is now data for last few decades now with every pandemic like influenza does increase your risk. Influenza is strongly associated with increasing your risk of acute coronary syndromes. Now, the pathology is again same, profound inflammatory state, cytokine surge, cytokine storm, and that makes stable plaques changes them into unstable plaques, which blocks your coronary and causes acute coronary occlusion, or it can cause arrhythmias because of myocarditis. The number 3 would be heart failure or cardiomyopathy. Now, this generally happens in the second week. Generally, they are worse to start with. They get better, and about 7 to 10 days, they start getting worse again. Similar mechanisms again. Profound inflammatory state, direct myocardial toxicity, sympathetic stimulation, LV dysfunction, endothelial injury, and all this eventually succumbs into heart failure or cardiomyopathy. So I think it is worth remembering COVID can certainly directly cause these 3 problems: ACS, arrhythmias, and cardiomyopathy. So we've talked about cytokine storm. We've talked about what COVID can do to your heart. I want to keep it short. I think we'll just end there. If you have any questions, please do let us know in the comment section. And I think it's time to eat healthy and look after yourself, exercise, because that's all. If you're healthy, if you don't have any risk factors like diabetes or high blood pressure, probably you will do well with the disease. And now when you get the vaccine, there's only one way to increase your immunity or to boost your immune system, if you like that, and that is probably to take the vaccine.